Hello, my name is Elias Jabbour, Professor of Medicine at MD Anderson Cancer Center. And today, I want to share with you the paradigm shift in management of CLL. This field has evolved drastically from alkylators to chemoimmunotherapy to small molecules. And in CLL today, we moved from chemotherapy with mainly FCR and BR to target therapy approach that could be finite or indefinite therapies. And the two big chapters are, or three big chapters are the BTK inhibitors, the covalent and non-covalent ones. We have the BCL2 inhibitors and CD20 antibodies. And I think cocktail of three of these drugs may lead to the cure of the disease. By cure, I mean offer a finite therapy with sustained remission and where patient can expect to have a normal lifespan. So how did we get there? Well, we had several randomized trials comparing BTK inhibitors to chlorambucil, and the first one with ibrutinib. Ibrutinib was found to be superior with a better PFS and better survival. And what we've shown as well that with the BTK inhibitors, we can negate the impact of biology at the baseline, mainly the heavy chain mutation status and the P50 mutation status as well. And therefore, BTK inhibitors, the first one was ibrutinib, was approved as a frontline therapy in CLL. Then we had another BTK inhibitor, acalabrutinib, where this drug was compared to chlorambucil obinutuzumab, either alone or in combination with obinutuzumab. And at the ASH meeting, we've seen 6 years update of the data, where the combination of acalabrutinib plus obinutuzumab was found to be superior with better PFS. No, survival has not been met yet, but there's a trend, and therefore today you can use either acalabrutinib alone or acalabrutinib with obinutuzumab. In the light of data at ASH of the improvement of PFS, I'm inclined to use this combination, although we need to see more survival and more data more survival data. Nonetheless, acalabrutinib was found to be better tolerated than ibrutinib that can cause some adverse events, mainly cardiac one, arrhythmias, bleeding, AFib, and others, and therefore, in that sense, acalabrutinib was better tolerated. Then we had zanubrutinib, another specific BTK inhibitor, a selective BTK inhibitor. When compared to BR in a Sequoia trial, it has shown an improvement in outcome as well. And therefore, zanubrutinib was added to the armamentarium of CL therapy upfront. It must know that the drug have a very good safety profile, but much more favorable than ibrutinib, and therefore has joined the frontline armamentarium. I must say here that in an abstract setting, zanubrutinib was compared to ibrutinib in a head-to-head trial in a relapsed setting, and zanubrutinib was found to be superior to ibrutinib with a better safety profile, and therefore this reinforced the position of zanubrutinib into the frontline. Now, all these options, all these trials all the drugs should be given in an indefinite way, do not induce high rate of MRD negativity, but should be taken in a sustained way. The question is, therefore, can we offer a finite therapy? And in that sense, CLL14 trial was a randomized trial comparing venetoclax and BCL and obinutuzumab to obinutuzumab and chlorambucil for 1 year of therapy. And of course, the venetoclax obinutuzumab was found to be superior in improving PFS. And as such, this combination was approved, but it was given for 1 year of therapy regardless of MRD status. And when we look at the subset analysis, the group with unmutated heavy chain immunoglobulin and those with 17p deletion did not do so well with this combination. Therefore, we did favor BTK inhibitor over a BCL2 inhibitor. No, then we moved to a combination of a BCL2 inhibitor and BTK inhibitors, and the first combination was done at MD Anderson, where we combined for 2 years venetoclax plus ibrutinib. The survival at 5 years is a 96%, 97% to normal survival in a finite therapy. And I think 1 year of therapy for all comers may not be good enough. 2 years was found to be superior. Now, the other trials done, the Captivate, the GLOW trial, they have shown that the combination of BTK inhibitor plus BCL2 inhibitors are superior to what we used to do with the chlorambucil, obinutuzumab, or chemotherapy, or others. Now, that the data from MD Anderson were confirmed into a trial report in New England by the UK group, UK Flare, with the combination of ibrutinib then offer sustained and long-term remission, and therefore I'm inclined to use the combination of BTK inhibitor plus BCL2 inhibitor to improve the outcome. No, is it the best combination? The answer is no, because we have a better BTK inhibitors. They're being tested right now prospectively, either acalabrutinib or zanubrutinib with one of the BCL2 inhibitors available. And finally, we're testing the triplet of obinutuzumab, for example, plus BTK inhibitor plus BCL2 compared to either BCL2 inhibitor plus rituximab or obinutuzumab or chemotherapy. And so far, the results known today have shown that the triplet is better than doublet. Of course, we need long-term survival data to be mature and to finally differentiate and to confirm or infirm whether triplet is superior or not. So in my mind, we made major progress in CLL today, and I think the future is to give the best approach to induce a deep remission and be able to stop therapy and cure this disease.